Now, if we go through if we think after that what may be happening, discoordinate growth. One fetus is good, another fetus is deprived. So this is called discoordinate growth. দেখবা যে একটা বাচ্চা বড় হয়েছে একটা ছোট হয়ে গেছে. It is possible due to placenta different placental problem, circulation problem like this, and presentation problem. So these are and then others are interuterine growth retardation, discordant growth, and death of the one fetus, and others what may be happened. So these are the during pregnancy. And another complication may occur that is very rare. I found in my life 2 cases maybe. That is conjoined twin. That's conjoined twin. That causes more. We cannot diagnose during pregnancy even on by ultrasonograph. During labor become obstructed. Then we try. Then it is. Then it strikes our brain. At that time ultrasonography is not so available. And then we found that most of the time sacrococcygeal region, that is more. Maybe in the abdomen, maybe sacrum. So these are the conjoined twin. And maybe Catholic there may be. So these are the conjoined twin. Now again we come back to the during delivery. So delivery become preterm labor, possibility of obstructive labor due to malpresentation and conjoined twins like this. Labor become prolonged. Actually theoretically possible, but practically labor is not so prolonged. But if malpresentation, obviously it would be prolonged. And if first baby is malpresentation, then we should do cesarean section. If any malpresentation, we can do cesarean section. Now, that is during complication during pregnancy, that is important. Complication during labor, complication during puerperium. Now, what would be the complication during puerperium? You always read by step, so that no problem. Puerperium, you think that is uterus become more larger. Yes. So there is called term sub-involution. During while you do the study puerperium, then you find the term sub-involution, slow involution of the uterus. You know the pregnant uterus then ultimately involuted by different processes, autolytic and other processes, and it comes return back to the pre-pregnant state. That is called sub-involution. And so sub-involution, that is during twin pregnancy, sub-involution is common. The rate of involution is decreased. Then every possibility of the infection. As their intervention is more, so there is every possibility of infection. Okay. Now, then puerperium. After that, you may ask, what are the region of the postpartum hemorrhage during twin pregnancy? There are 4 to 5 factors. What are the causes, or why there is every possibility of the postpartum hemorrhage? তোমাদের কি মনে হয়? Uterus more enlarged and more distension. So every possibility of atony. Number 1, atony. So when multiple pregnancy, you always prepare blood. At any time needs blood. So a distended uterus follow to atonic uterus. Another is large placenta. So it takes more time to separation from the uterus. So it causes one of the cause of the postpartum hemorrhage. Another is long time open up the decidual sinuses. Long time open up. So it also causes that is postpartum hemorrhage. And another is what you told. Maybe injury, due to handling, of the malpresentation. It may be associated with the trauma. That is also associated with postpartum hemorrhage. And others are the folic acid deficiency, coagulation deficiency, coagulation factor deficiency, G2PET, also one of the causes of the postpartum hemorrhage. Okay, so these are the causes of the postpartum hemorrhage. Need to repeat or no need to repeat, as it is so important. Atony, long time of separation of the placenta and open up the sinuses. Very good, thank you. So these are the factors. So now again, it is a big chapter, but I need to finish in one lecture. So shortening of the topics. Then for management, management, we should correction of the anemia and the frequent antenatal checkup. When needed, you should need to come. Maybe fourth standard is antenatal care, but here it needs more due to anemia, due to hypertension and others. Sometimes need admission if there is complication. Suppose associated with the hypertension, need to control hypertension by admission. If anemia more, they need to correction. Anemia by blood transfusion, need admission. And others, if needed at any time, maybe maternal distress, so need admission, maybe polyhydramnios. You know the term polyhydramnios, it is associated with the multiple pregnancies. So maternal distress sometimes more. So at that time need admission. So polyhydramnios, hypertension, anemia, patient may need admission at any time. And what would be the planning of delivery? Planning and delivery, most of the time nowadays we prefer cesarean section, as that is so common is vertex and other babies malpresentation, and patient cannot tolerate such a long 40 weeks, cannot want to go up to 40 weeks at term, and sometimes come with the preterm labor, with the fetal distress or maternal exhaustion, and so many times. But basically we should try for the vaginal delivery if the first baby is vertex. And cesarean section only indicated when really indicated, that is if other associated factors like severe PT, first baby is malpresentation, and there is any form of obstructed labor like this, so you should do in that case cesarean section. Then anything you can ask me. After that we can go to the, I do not describe the clinical features, that is during pregnancy antenatal examination. Antenatal examination, that is a single pregnancy and multiple pregnancy. Same shape, size and shape of the abdomen? No, it would be more than that of the normal single pregnancy. And there is anemia, you know the anemia, hypertension may be associated. And how you suspect there is fetal, that is multiple pregnancy, how you suspect? That if you have, during abdominal examination, there is multiple fetal parts, more than 2 fetal pole, and they are associated with the polyhydramnios maybe, and by auscultation 2 distinct fetal heart sound into separate area, and in between them there is silent area. So auscultation you can alone or need 2 persons. There need 2 persons. 2 persons have in the same time we need to auscultate. And nowadays more that we easily ultrasonograph we want. So what is the role of the ultrasonogram? Number 1, earlier diagnosis. There's 2 fetus. Sometimes misdiagnosed. If more earlier, more before 10 weeks, sometimes yolk sac separately diagnosed as a twin pregnancy. So we need to wait until 10 weeks for proper diagnosis of the twin pregnancy. Better. Then viability, then position, localization of the placenta. Okay, localization of the placenta is important, size of the placenta, and baby IVGR or not, discordant growth or not. Like this we need to do the ultrasonogram. Then I told already the planning of delivery. Then any other things? Here I want to mention another, that is disorder of the amniotic fluid. That is important. Just I want to tell 2 or 3 points. Amniotic fluid disorder in relation with this chapter, and abnormalities of the placenta and cord. So amniotic fluid disorder means there is 2 terms, polyhydramnios and another is oligohydramnios. So all of us you know. At term means after completion of the 37 weeks, if amniotic fluid is more than 2 liters, that is called polyhydramnios. And polyhydramnios, that is multiple pregnancy is one of the common. And what are the others? What do you think? If the anencephaly, open spina bifida, esophageal atresia, cleft lip, cleft palate, then there is a chance of the polyhydramnios. And another is RS isoimmunization. You know, the abio incompatibility is RS isoimmunization, also associated with the polyhydramnios. So congenital anomalies of the fetus and maternal problem like this, twin pregnancy and RS isoimmunization, abio incompatibilities are associated with polyhydramnios. Then, polyhydramnios, what do you think? The maternal, there is when there is 2 terms, only acute and chronic. Chronic is mother can adopt, but acute is problem. And we can, that is more distension of the abdomen, maternal distress like this. When polyhydramnios is more, and diabetes mellitus can cause polyhydramnios. Yes, diabetes mellitus. If GDM patient, mother is GDM or diabetes mellitus, as placenta is large, so more formation of the amniotic fluid. You should know how amniotic fluid is formed, amniotic fluid, function of the amniotic fluid, circulation of the amniotic fluid, everything you should know, basic science. So these are the problems. So what is the management of the polyhydramnios? So management depends upon the management depends upon the causes. And another is, you know, that any other way to reduce the formation of the amniotic fluid. Yes, there is some COX inhibitors, that is prostaglandin inhibitors, like indomethacin, NSAID, some NSAID can be used to reduce the formation of the amniotic fluid. COX-2 inhibitors like this. And there is a term amnioreduction. Amnioreduction, that is to bring out the amniotic fluid by ultrasonographic guidance. We can reduce the amniotic fluid. Can we decrease the secretion of the amniotic fluid? Okay, thank you. So these are the way, and there is amnioreduction also. Okay, amnioreduction. I told also amnioreduction. Okay, then what is oligohydramnios? When the formation of the amniotic fluid less than about 25% of the normal secretion, then it is oligohydramnios. At term, how many? Less than 500 ml. And what do you think about the possible causes of the oligohydramnios? The placental insufficiency, one of the cause, and amniotic placental infection, and if the fetus is associated with congenital infection or congenital anomalies, like kidney impairment, sometimes renal agenesis, fetal renal agenesis associated with the oligohydramnios, and also silent, sometimes ruptured membrane also associated with the oligohydramnios. So management depends upon those. So you should go through the books and should finish the chapter, okay? And tomorrow I manage one class as that is like this 10 to 11. There is dermatology class. I arrange tomorrow. I also take the class. I may review the infertility. Okay. Thank you.